So let's talk about full thickness resection in the upper GI tract, current status, my disclosures. So when we are talking about endoscopic full thickness resections, we're talking about two different concepts. So we're either talking about primary breach of the GI wall before, during resection, and then secondary closure. That's what surgeons have been doing for centuries, making a hole and then stitching it up. And we have this with secondary wall closures. It's called this exposed EFTR. We have this modified ESD. We have this stir and the POET procedures with coming with submucosal tunneling. And we have the other principle is non-exposed EFTR. So we clip suture first and cut later. We're making a wall duplication. So we are not opening the GI wall. We do these wall duplications either with the FDRD system, with a clip, or we do it with a Gerdix device I've already presented you before. So just brief, this standard ESD, you're not opening the wall. With a modified ESD, you're going right through the adventitia. With the stir procedure, you are tunneling. With the exposed EFTR, you're making a hole and then stitching it up. And with this neo-EFTR, with non-exposed, you are making a wall duplication first and then cutting the lesion. When we're talking about endoscopic full thickness resection, we must be clear, what are we going to resect? Are we going to resect epithelial lesions, or are we resecting subepithelial lesions? Depends. For epithelial lesions, we need it only for the duodenum, because otherwise we can do with ESD, we can do with EMR, that's fine, we're not going to be able to use it in the esophagus, and then we will use it for non-lifting primary or recurrent adenomas in the duodenum. Other story with the subepithelial lesions, if we are treating subepithelial lesions, we naturally have to do a full thickness resection, we have to do a EFTR, otherwise we are not going to be able to take them out. What do the guidelines say? It's a statement from the ESGE concerning subepithelial tumors. If they are small, you can follow them up, making endoscopy, endoscopic ultrasound every 1 or 2 years, or you can take them out less than 2 centimeters. If they're larger than 2 centimeters, you need to take them out anyhow. And in the duodenum, you need to take out every subepithelial tumor. So, in Southeast Asia, they're doing a lot of this open EFTR. So they make a perforation. Professor Zhu from Shanghai is an expert in it. I always a little bit afraid when I look his interventions. Making a hole, you're taking it out and then somehow stitching it up. It works most of the time, but actually currently I think we have not the absolute control about closing and complication treatment like the surgeons have. There was this endostapler from Power Medical. The surgeons know it very well. We use it with Georg Kehler for endoscopic resection for stapling in the stomach, but then it was bought also by Covidian and also shelved. We thought it would be developed so we could actually do stapling, but this is not a thing that has been pursued. What came was the big bang with a per-oral endoscopic myotomy by Pastrica and Sumiyama. They did the prior work in animals, and Haruhiro Inoue did the first clinical case. And from this came this whole bunch of third space endoscopy. I think in the next talk we talk about it more in detail, and I will focus on this submucosal tunneling endoscopic resection and the POET for lesions in the esophagus and in the gastroesophageal junction. You see here, this is one in the diameter, a 3.7 centimeter lesion, and you just do like in the POEM procedure, you're preparing your tunnel, you're injecting toluidine blue, and then you find this white guy, and then you know this white guy is a leiomyoma. but then you need to prepare it and to take it out from the paragastric tissue. It's a little bit time consuming, and finally you have everything prepared. It's actually very little blood usually. Takes a little while, but then you just take it out with the snare to retrieve it, and then you clip close like in poem, and then you have something like this, and this was a leiomyoma. So you can do it endoscopically fine, but should we do it endoscopically? There's a different meta-analysis that showed pretty nicely that we have a technical success rate in the 90s and a complete resection rate in the upper 80s. And there was one benchmark trial from Beijing, and they looked at esophageal subepithelial lesions, and they compared this stir procedure with a video-assisted thoracoscopic resection. And you see this, the size of it was 19 millimeters, mostly in the middle esophagus, and nearly all of them were leiomyomas, only 3 cysts at the GE junction. And this really showed the superiority of the endoscopic approach. The operation time was, of course, much lower compared to what the hospital stay was the same, I don't know why, and the costs were, of course, much lower. And especially the complication rate was much lower in the stir procedure group. And as a complication, if you do a VATS, you always end up with a thoracic tube, and this was not scored as a complication, but so much more comfortable for the patient, much cheaper and much shorter. So the endoscopic is winning out here. And you can see here, it also depends. We can do it up to a size to 3 to 4 centimeters. This is a nice study. They looked how often is the conversion. When did this group converse to thoracoscopic resection? How about the stomach? In the stomach, it's a little bit different. No, it's not running. Okay, so never mind. But it's a little bit tedious because this gastric wall is so thick that it's hard to take the thing out. So we're coming to this non-exposed resections. The neo-EFTRs, you make the defect closure before resection with the FDRD device, or you do it with the Gerdix device. The OTSC clip, I think everything is familiar with it. It's not just another clip. We're using it in a lot of endoscopic treatments. And we pioneered it with a company and developed the device. And it's mostly used in the colon, but also in the upper GI tract, coming with a balloon. It's a little bit less diameter. We did several studies for the lower GI and the upper GI, and for the upper GI we did a pilot study for gastric gysts and nets. The small ones, they have to be less than 1.5 centimeters because otherwise you cannot pull them into the cap. Published this a couple of years ago. And the major problem with all the subepithelial lesions in the stomach is even if they're small, it's not so easy to get the diagnosis. So that's why the ESG is saying if you can either make surveillance or you can resect the lesions. And it's done pretty fast. It takes 30-35 minutes. The technical success rate is in the 90s, R0 resection high. But the problem with it is that you never know what's in it. You have ectopic pancreas in 34.5%, you have gysts only 20%, and nets only 10%. So only 30% of the lesions you resected actually would have needed to be resected. But you have in 100% the diagnosis. And as I mentioned, the ESG suggests smaller than 2 centimeters alternative to surveillance, you can take it out. So you have to discuss it with the patient. If the patient agrees to be surveyed every 2 to 3 years with endoscopy and endosonography, then it's fine. And if he insists that this thing should be resected, that you could take it out with the FTRD. The other indications are these epithelial lesions in the duodenum. This is a recurrent adenoma after surgical resection in a 45-year-old patient in the duodenum. So the next stop for this lady would have been a Whipple procedure. So, and this is something different than just a colonic segmental resection. And we did this like we're doing it in the colon, and this was the result. We resected this, the recurrent adenoma that was caused not lifting, no chance to do it with EMR or EST. And we published our data also a couple of years ago. There's not much publication on this issue. 20 patients published from our group, 13 adenomas, technical success rate 85%. Because you cannot always pass the pylorus, this is a minor problem. The results are a little bit not as good as in the colon, but quite reasonable, and complication mostly minor bleedings. There's another group from Mayo, 56 patients in 30 centers recruited in Northern America, coming up with the same results, and there's a meta-analysis. 16 patients, two of these studies are from our group, this one and this one, 142 patients, and you see the technical success rate is 87%. The R0 resection rate 80%, 2 adverse events, 2 recurrences, even although not all were resected, are 0. So these are the small guys, but what do you do with the bigger guys? With the large guys, you either have to do surgery, or you can use the Gerdix device as I showed you. And this is basically, you're not using non-resorbable but resorbable sutures. You make this wall duplication. Here, this is a typical gist in the distal corpus. You just make like with a stapler, you staple it at the base of the subepithelial tumor, which is a gist. And you have like 2 or 3 sutures at the base of the gist. And then you snare resect it with a double channel endoscope or additional working channel attached to the endoscope, because you're using an anchor, endoscopic anchor, and resect it. You have sometimes a little bit bleeding after it. You can stop it, of course, with a co-grasper. And if you have the feeling that this is not completely closed, then you just put another suture over it, and then you're done. The sutures will fall out like after 4 to 6 weeks. This is the resection specimen. Was R0 resected. Gist. The patient was spared surgery and was happy with it. So these are our results. 55 patients located all over the stomach. The size larger than 2 centimeters in 31 patients. We had macroscopic complete resections, 95%, histologically confirmed R0 resection in 87%, gist tumors 62%, and we had only minor complications, no need for surgery, no death, and we received for this the Endoscopic Best Paper Award in 2016. So let me conclude. Endoscopic full thickness resection in the upper GI tract, it's reality, it's mainstream today. And I think it's a major step forward in interventional endoscopy. We are not limited anymore to the endoluminal resections. This non-exposure EFTR, I think it's effective and safe. So we're not risking running into problems because we're not opening the GI wall. I would say this is the Western way. In Southeast Asia, they're much more, especially in China, they're much more aggressive, opening the cavity of the stomach. And I think resections can be done in the whole GI tract except of the esophagus, with these devices, and the killer indication is non-lifting neoplasias and subepithelial tumors. Of course, you need expertise and close cooperation with your surgeons, and the limitation is the size and the location of the tumor. So when in doubt, take it out, but take it out endoscopically. So EFTR is about location, indication, and technique. If you're looking at the esophagus, the subepithelial, you're only dealing here with the subepithelial tumors, leiomyomas or granulosa cell tumors. There's hardly ever a gist, and if it's a gist, it's at the GE junction. In the tubular part of the esophagus, almost always benign tumors. You can leave them. You need to treat them only if they're making symptoms. And then you go for the stir, you go for the subepithelial tunneling resection. In the stomach, you're also dealing with subepithelial tumors, but subepithelial tumors you need to resect, at least when they are 2 centimeters and larger. It's about GISTs and about neuroendocrine tumors. And there, for the big guys, you take the GERD-X device. For the smaller guys, you take the FDRD system. You can go for subepithelial tunneling, but it's much more cumbersome than in the esophagus or at the GE junction. In the duodenum, we're talking not only about subepithelial tumors. In the duodenum, the subepithelial tumors are nearly 100% neuroendocrine tumors that need to be taken out anyhow. But we're also talking, as I've shown you, about non-lifting recurrent extrapapillary adenomas. And here, the duodenal FDRD rules, and for the colon, of course, the colonic FDRD. Thank you very much for your attention.
Thank you so much. We have maybe for one question, please. Mashallah.
Excellent talk. For an old guy like me, how long I need to do all these procedures? I will send it to you. I'm not ready to learn it. How many cases I should do before I become expert? The second most important question for me, as I'm working in a bariatric center, is the leak, gastric sleeve leak. And we have this big hole, and then you decide, shall I try Ovisco, or shall I put 3-4 pigtails, or just put a mega stent? Can you tell us how do you decide the size of the leak to put the Ovisco, or do you go with the stent, or do you go with the pigtails, 4 or 5 pigtails in the leak?
That's a good question. I think that the problem with the sleeve leaks is, as I mentioned before, you're pressurizing the stomach. When you do a sleeve, you're pressurizing the stomach. It's not like a surgical side effect or anything like that. It's not a mishap. It's what you can expect in a certain amount of patients. So the surgeon's done everything fine. And if you try to close it with a clip, there will be the same pressure, and it will open. I'm a fan of the Ovesco clip, but not for fistulas or.
So not for fistulas.
So
okay.
that's of the.
Because they were suggesting why you don't use a big Ovesco. I was reluctant.
Yeah.
No,
not for these
Very
indications. And then if you are sure that behind the wall everything is fine, then you can put in a stent. Otherwise, you will generate an abscess formation.
Do you use pigtails?
Dr. Hamad,
exactly.
Oh, sorry.
I think the data is clearly showing there is no benefit from Ovesco in an acute situation with leaks. So either internal drainage with a double pigtail, or you do a mega stent. It depends on the size. Is it contained cavities? Is it not contained cavities? What's the pressure inside the stomach? Do you have an angulation or twist? This is all factors that will affect your decision about what to do in your next step.
I thought they are not putting the stitch in opposite each other, so this will cause the twisting and cause the cause of leak. Is that?
No, you have a high pressure and you have an inflammation. And if you have an inflammation, you can stitch, you can clip, you can do whatever you want. It will always open because you have an inflammation, and additionally you have high pressure. Therefore, trying to close it, it will be closed for 1 or 2 days, and then it will open again.
Thank you so much.
Thank you.